Good morning, everyone. What a fun way to start off a webinar. Thank you for that wonderful playlist. Welcome to everyone. We are so excited to have you all in this webinar, looking at how different folks are leveraging sexual orientation, gender identity, race and ethnicity, and language data to advance equity within behavioral health. My name is Elisa Feld. I use she, her pronouns, and I am with the County Behavioral Health Directors Association, representing county behavioral health directors across the state. We have been a part of the Delta Collaborative, and one of the things that we are really proud of in our association is how we've really been grounded in equity. And we're looking forward to highlighting how several counties have been leveraging data to address disparities, and really lifting up how both county behavioral health and community health centers have been innovative and have started to standardize in the collection of race, ethnicity, and SOGI data. Want to extend a very special thank you to all of our partners, but in particular to CIBHS for supporting this webinar with their tech support. And with that, I'm going to hand it over to Peter.
Thank you so much. And just adding on to the thanks, huge thank you to the JSI Program Office, who operates our Delta Center, California. But good morning, everyone. My name is Peter Dye, and I'm the Associate Director of Care Transformation at the California Primary Care Association. And we are an association that represents community clinics and health centers across the states. That also includes FQHCs or federally qualified health centers. I wanted to share a little background about Delta Center, California, which really helped accelerate this work. Delta Center, California brings together behavioral health and primary care leaders across the state to accelerate care improvement and integration through policy and practice change. A huge thank you to the California Healthcare Foundation and the Robert Wood Johnson Foundation for funding the Delta Center, California. And our ultimate purpose is to advance health policy solutions and create a care system that better meets the goals and needs of individuals and families and addresses racial and economic disparities. Just to give folks a little background about our structure, CPCA and CBHDA participate in a state roundtable with 9 organizations that represent safety net, primary care, and behavioral health providers, and we collaborate on shared priorities. Part of the Delta Center California structure also includes a learning lab with several local teams implementing projects to advance primary care and behavioral health integration. Our role on the Delta Center California has been in the state roundtable, and as a group, we really worked around equity-related data as policy and practice solutions. And we're really pleased to share this webinar on this topic, including one of the colleagues in the Delta Center California local team, Dr. Vanessa Blum. Now, next slide, please. I'll give folks an idea of what we have planned for today. So we have an excellent panel for folks today. And throughout the webinar, please feel free to use the chat function to submit your questions. We will be answering questions in a Q&A session at the end. At the end, during the Q&A session, we'll be going over the questions that were put into the chat. But at that time, folks will be able to raise their hands to be unmuted to ask questions directly to the panel. And a question that I always ask is if this webinar will be available afterwards, and yes, it will be. The recording, slides, and also a graphic recording will be posted on the Delta Center California website following this, this webinar. And now it is my pleasure to introduce our first speaker for today. We have Dr. Alex Kruligan from the National LGBTQIA+ Health Education Center as part of the Fenway Institute. And I'll pass it over to you.
Thank you so much for that introduction. Hi, everybody. Great to be with you all. Looking forward to today's session. As a former 7-year resident of California myself, I'm coming to you from Boston, Massachusetts today, and I'll be talking about collecting patient sexual orientation and gender identity data. And looking forward to hearing from my colleagues who will be presenting with you all today as well. Next slide, please. Great, next slide, thank you. A word about Fenway Health. We're a federally qualified health center in Boston. We are now in our 52nd year as a health center. And from the beginning, Fenway has been focused on providing the highest quality care for sexually and gender diverse people. Certainly once the HIV epidemic hit in the early 80s, that became a primary focus. We're now the largest provider of LGBTQI plus health services in New England. We're the largest provider of HIV services in New England. We see over 2,300 people living with HIV in primary medical care each year, and the largest provider of transgender health services in New England. We see over 4,500 transgender and gender diverse people in primary medical care on an annual basis. We have an institute within our health center, the Fenway Institute, that focuses on research, education, training, advocacy, and policy for LGBTQI plus people, and we have a national training and technical assistance partnership with the Bureau of Primary Healthcare, where for basically a decade now, we've been doing SOGI data implementation, training, technical assistance, capacity building across all 1,400 or so federally qualified health centers in the country, including extensive work over the years with health centers in California, and we've worked quite a bit. We've been privileged to do so with the California PCA as well. Next slide, please. We have a lot of resources on our website related to SOGI data collection, an intersectional perspective on this, and that includes webinars by national experts, interactive learning modules, best practice guidelines on SOGI data collection, recordings from our national conferences we do with Harvard Medical School continuing education that are all archived and available for free with continuing education credits. So please feel free to check all this out at lgbtqiahealtheducation.org. Next slide, please. Why is it important to collect SOGI data? The Institute of Medicine, Healthy People 2020 and 2030, most recently the National Academies of Sciences, Engineering, and Medicine, convened national experts, reviewed the existing literature, and concluded that there really are unique health disparities experienced by LGBTQI plus people, and that the way to address these health disparities, to mitigate their adverse impact, is to know the sexual orientation, gender identity, sex development of our patients, so we can provide culturally tailored responsive care based on that, so that LGBTQI plus folks can enjoy the same standard of health as the general population. It also allows us to engage in continuous quality improvement, where we can see what the health outcomes are for our LGBTQI plus populations and subpopulations versus the general population, so that we can do population health management and quality improvement based on that. Next slide, please. There are many health disparities experienced by LGBTQI plus people across the lifespan, from childhood through adolescence and across adulthood. These are largely driven by experiences of minority stress, gender minority stress, sexual minority stress, the impact of stigma and discrimination on people's access to care, their mental health, their trust of health systems, and ability to engage in and receive equitable, culturally responsive, high-quality care. Next slide, please. We think about achieving health equity for LGBTQI plus people in 4 categories. We're thinking about our patients, we're thinking about our staff in healthcare settings, and we're thinking about trainees for those of us who work at training sites as healthcare organizations. We want to end invisibility of LGBTQI plus people in healthcare. That means asking all patients systematically in a sensitive, effective way for their gender identity, sexual orientation, sex development. There's clinical education. There are unique practices we engage in for LGBTQI plus communities that are different than what we do for the general population. There's sensitive and effective communication more broadly that we'll talk about today, and how to build inclusive, affirming, responsive healthcare environments as well. Next slide, please. When we do talks all over the country, we ask people with a show of hands when in person to indicate if they've ever been asked by their own healthcare providers for their sexual orientation or gender identity. We've never had more than half the room raise their hands, even in San Francisco, Boston, Los Angeles, New York, Washington, D.C. So admittedly, as clinicians, we do a terrible job of systematically asking all our patients these questions. We do focused histories, we cut corners. So we need another system within healthcare settings, another line of defense, and that's typically frontline staff, registration, intake, front desk, and so on. Next slide, please. Here's a real example of why this matters. This is a de-identified patient. Rodrigo is a 40-year-old trans man receiving care at a health center that wasn't systematically, sensitively asking about gender identity. He therefore didn't feel comfortable disclosing his trans status. One day, Rodrigo came in with pelvic pain and spotting. It turns out that he had developed cervical cancer that was totally preventable. However, nobody thought to offer him and provide a cervical pap test. And when we hear people say, well, I don't want to ask about sexual orientation and gender identity, I don't want to be rude and offend people, the rudest thing we can do and the way we're going to offend people is by not asking for this critical health-related information and having these really unfortunate adverse health outcomes for patients that are preventable. Next slide, please. Healthcare staff often assume that patients will be offended by these questions, won't feel comfortable answering, will choose not to disclose. Studies, including ours and other people's studies, have shown that the vast majority of patients of all racial and ethnic identities in different geographies across the US, and mostly cisgender straight people, will gladly answer these questions, understand that they're relevant for care, and state that they'd be happy to answer these questions again in the future. And it's a lot of anticipatory anxiety on the part of staff. We're not confident and competent asking these questions, so we project that onto patients, but they know they're going to get asked all kinds of questions when they go to access healthcare and are generally happy to answer. Next slide, please. We have many tools on our website for free for guidance in collecting and utilizing SOGI data. This is our Ready, Set, Go toolkit we developed for the Bureau of Primary Healthcare that's disseminated to all health centers across the country and primary care associations. Next slide, please. Clinicians need to know the basics of concepts and terminology related to sexual orientation, gender identity, and sex development, how to have these conversations with patients and families, and how to tailor their approach. Front desk patient registration staff need to learn about sensitive and effective communication and how to document this information in the chart for other staff to know how to use. And patients deserve to know why we're asking these questions, that it's directly relevant to their care, that we're asking all patients so they don't feel individually profiled or targeted, that they can choose not to disclose if they don't want to, and that we're only going to use this in a confidential way directly relevant to their care. Next slide, please. Some staff will need extra coaching and reassurance. Supervisors can say, we're not trying to change anyone's religious beliefs, political persuasions, values. This is about providing the highest quality care for all patients who walk through our doors. And if we appeal to our staff's sense of professional idealism and competence, that's often very motivating for them. Next slide, please. We have demonstration videos on our website that show how to have these conversations about SOGI at the front desk. If a patient changed their name, if a parent comes in with a transgender or gender diverse child, if we're working with an adult, somebody objects to being asked these questions, if someone is best served in a language other than English, like in Spanish, for example. So these are 1 to 3 minute bite-sized videos you can use to practice for yourself or to train your colleagues. Next slide, please. Here are patient pamphlets we have on our website you can download for free. You can have these in the waiting room at the front desk that explain in the 10 most commonly spoken languages in the US why we're asking these questions that's relevant to care, that we're asking all patients, that folks can choose not to disclose, that we're going to use it in a confidential way, only directly relevant to their care. Next slide, please. We could ask these questions through the patient portal if your electronic health record has one that allows people to do so in the privacy and comfort of their own home. We could ask at registration where you need to set up with some privacy. It can either be on the phone during intake or in person. We do this with electronic tablets at Fenway, for example. Or you could ask initially in the provider's office, but as we pointed out, providers aren't great at systematically asking all patients these questions. So in practice transformation initiatives, we've been part of the National Association of Community Health Centers and the CDC. Seems like it's best to ask this at registration or at intake. You can click ahead here, thank you. Great. And for gender identity data, we ask all patients what name they go by, what are your pronouns? We can say some people's pronouns are he, him, his, some people's pronouns are she, her, her, some people's pronouns are they, them, theirs. What are your pronouns? We can introduce ourselves with our own name and pronouns to normalize that. We can ask what the name is on insurance that may be different than the name they go by. what their current gender identity is, and what their sex assigned at birth is. Next slide, please. We've also published the first guidelines this past April on pediatric SOGI data collection, and we recommend asking about gender identity before puberty. As young as 3 years old, patients can articulate what their gender identity is. Parents may come in with concerns about that. Sexual orientation, we start asking around the time of conversations about puberty, around 12 years old. And providers should ask these questions in private if they have the chance, so that they get an unbiased answer from the child themselves, not with their parent or guardian there. Next slide, please. Some people's pronouns are ones we're more traditionally familiar with, like he, him, his, or she, her, hers. Many people's pronouns are they, them, theirs in the singular. There are also neopronouns like ze, he, or hers. All this takes practice. Better to practice with colleagues or at home than to practice with patients for the first time. Next slide, please. If you apologize, just say, I'm so sorry, I didn't mean to be disrespectful. If you make a mistake, apologize, say, I'm so sorry, I didn't mean to be disrespectful, and correct yourself. That's a way to diffuse a difficult situation, reestablish a constructive dialogue. Next slide, please. We all have gendered language we've been socialized to use. Better to think about non-gendered ways we can refer to people without making assumptions about their sexual orientation or gender identity based on how they look or how they sound. So instead of saying, hello, may I help you, ma'am, or how may I help you, sir, we can just say, hello, how may I help you, and be just as warm and welcoming. Next slide, please. If you're not sure about a patient's name or pronouns, just ask it in a helpful, non-judgmental way. You could say, could your chart or insurance be under a different name? And again, if you make a mistake, don't dwell on it and get flustered. Just say, I'm so sorry, I didn't mean to be disrespectful, and correct yourself. Next slide, please. We can hold each other accountable. If someone makes a mistake, okay to politely correct them and point out that your colleague's pronouns are in fact they, them, or to say those kinds of comments are hurtful, don't create a respectful work environment, something along those lines. Totally appropriate. You can link it back to the missions or to the organization's mission and vision for equity. Next slide, please. We have tools on our website for revising policies, procedures, and forms with universal language. Feel free to download this from our website again. All of this is at lgbtqiahealtheducation.org, the link here on the bottom. Next slide, please. You can have gender inclusive avatars like this on forms for people to indicate the location of pain or other symptoms. Next slide, please. And we have tools for working through implicit bias. On our website, you can download this for free. We developed for the Bureau of Primary Healthcare to help us understand that we all have implicit bias, even those of us who are LGBTQI+, that we need to work through it to prevent its adverse impact on our communication, rapport, and decision-making, and its adverse impact on patients' perception of the quality of care they receive, their adherence to recommendations, their follow-up, and health outcomes. Next slide, please. Thank you so much. Appreciate your time, and I look forward to hearing from our colleagues.
Thank you so much, Dr. Krull, again, for providing such great resources and examples from across the nation, and really giving a overview to set the stage for the rest of this webinar. It's now my pleasure to introduce Dr. David Tian, who's the medical consultant in the Quality and Population Health Management Department at the Department of Healthcare Services. Dr. Tian, the floor is yours.
Great, thank you so much, Peter. With my talk, we're going to take a zoom out and talk about some of the data landscape and some of the policies around how we capture SOGI data and also real data, mainly also to show how much room there is for improvement and the collective work ahead of us in capturing the most accurate and full information about folks in our communities. Next slide, please. And so just as background, DHCS is the Department of Healthcare Services, and we fund healthcare services for California's Medicaid program, which we call Medi-Cal. And there are 15 million beneficiaries in the Medi-Cal program. And Medi-Cal is proud to be a national leader in expanding access to health services for diverse communities, including provision of full scope services for many California residents who do not meet federal immigration status requirements for Medicaid. And there's a link for more information on the expansion of coverage in the future. And in addition to the Medi-Cal program, DHCS also oversees some incentive payments to public hospital delivery systems for quality improvement programs such as PRIME and QIP. And I'll get to why that's relevant as well in terms of incentives to capture full information about beneficiaries. Next slide, please. And so DHCS is really committed to improving health equity, and there is an overall health equity framework of which data collection and stratification is a key component. DHCS's vision here is to have complete, accurate data on race, ethnicity, disability, and language, SOGI data, and that this information will be used for Medi-Cal members to illuminate and address healthcare inequities across DHCS programs. Next slide, please. And just so that you know, DHCS is also really focused on addressing healthcare inequities and disparities. And so there are many goals in our comprehensive quality strategy, but I wanted to lift up our so-called bold goals that really focus on closing racial and ethnic disparities in well child visits and immunizations and birthing outcomes for Native American persons and Black persons, to improve maternal and adolescent depression screening by 50%, and to improve follow-up for mental health and substance use conditions by 50%. And this will really hinge on our ability to harness efforts to standardize and improve our how we measure race and ethnicity, and also some changes that we hope to achieve and how we capture data when people first sign up for health insurance. Next slide, please. And so to set the stage, the collection of sexual orientation, gender identity, race, ethnicity, and language data is complex for the Department of Healthcare Services because of this intersection of laws, regulations, data mapping standards, and guidance from both the state and federal levels. And so there are a lot of different factors at play that both constrain and guide what DHCS is able to do. And so I just wanted to highlight a few of these. The first is there's federal guidance from the Center for Medicare and Medicaid Services, including a standard application and what we're actually allowed to use on the paper application in particular when we ask for people's information. And also there are standards of data mapping, meaning that there are federal standards for what types of data fields there are and what options there are in certain data fields. In addition, there are state laws in California that also impact the collection of SOGI and real data. The first to highlight is AB 959 that mandated collection of SOGI data using 3 standard questions, many of which were on the standard work that was shown during the last presentation. The next is SB 179, which mandated and allowed noting non-binary gender identity. And finally, AB 1726, which required California agencies to help collect ethnicity data for each major Asian and Pacific Islander group in an effort to disaggregate data and actually take a zoom in into communities that may not be served by more aggregate constructs of race that are most commonly used. Next slide, please. All of that said, I'm going to present to you the current state and some efforts that we've done to make things better. And so we're aiming to increasingly collect complete and accurate data on sexual orientation through and gender identity through multiple venues. At enrollment, we're only allowed to collect certain types of information, and most things are optional so that there's no discrimination, actually. So we don't mandate that people report many types of information. Due to some of the federal constraints that I mentioned earlier, the current paper application simply asks for someone's sex as male or female without an option beyond this binary construction. And then the online application, which DHCS has more leeway over, we were able to add. You'll see that there's a conflation of sex and gender identity here, right? But I think that there is this question about what someone's sex is, and with some additional options for noting that someone is transgender with these 2 additional options. There are additional data collected as optional questions at the end of the application on the online version only, and that's one way that DHCS is getting at trying to get more full information. And then the data are received by DHCS from other public programs, which may collect information in more granular ways that are probably more aligned with best practices in terms of some of the practices mentioned earlier from data collection standards. And also, DHCS did promote the collection of full SOGI data through the PRIME program, which were dollars given by the department to public hospital systems. And when the bill that I referenced earlier passed that mandated the collection of SOGI data using the 3 standard questions, DHCS actually made it contingent for public hospitals to receive incentive funding to increasingly collect complete data in better and better ways over succeeding years. And finally, we are working on an effort called the Beneficiary Contact and Demographic Information Initiative, where we're taking a hard look at how we collect information from beneficiaries and how we align that across our various systems at DHCS. And there's ongoing consideration of how things like SOGI data, real data, as well as pronouns are captured insofar as this is an important area of improvement, as we've noted. Next slide, please. And in terms of race and ethnicity data collection, we are also trying to walk across the organization's many functions and try to standardize some of the ways that we collect data on race and ethnicity. You'll also see that there are several different standards and approaches and some federal guidance as well. Our current practices align with national data standards, such as the CDC's race and ethnicity code set, as well as state laws, such as the one I mentioned earlier, which disaggregates Asian American Pacific Islander ethnic groups from the Asian race category. The current race and ethnicity fields that are used on the paper and online applications are quite, I think, are quite common in California insofar as ethnicity is generally kind of Hispanic, Latino, or Spanish, using those 3 words as potential options for overlapping identities, and then seeking additional information about ethnicity after that. Whereas some ethnicities or some groups that are commonly referred to or thought of as ethnicities, such as the Asian ethnic groups, are actually in the race question. And this has some things to do with how data are captured and stored and what federal information and data are required. For instance, there are federal requirements to collect ethnicity data on whether or not someone is a Hispanic, Latinx, or self-identified Spanish. However, there are not similar standards on the collection of Asian ethnicities, which is mainly due to state policy, as I mentioned earlier. The good news is we are trying to make data collection better, and we're actively trying to think about how to use these data to improve quality reporting for managed care plans. And so there are more than 30 measures that all managed care plans are required to report every single year. And many of those measures are stratified by race and ethnicity to identify potential disparities and inequities due to factors such as racism, as well as language access. And more on this approach is covered in our comprehensive quality strategy. And one issue that I wanted to lift up also is because we don't force people to share information about their race and ethnicity, there's a high rate of no response, meaning that some of these data might be inaccurate and certainly or just unavailable. And certainly it's incumbent on all public agencies to build trust with communities and people in our community so that they are comfortable sharing this information insofar as recent political environments have highlighted the risk to certain communities, especially given kind of variations in federal policy. Next slide, please. Oh, great. So those are all of my slides, and I look forward to answering your questions at the Q&A. Thank you.
Thank you so much, Dr. Tian. That was very helpful to kind of get the lay of the land of where California is at and how that fits into to the broader federal landscape. It is now my pleasure to introduce Dr. Vanessa Blum from Marin County Behavioral Health and Recovery Services. Dr. Blum, I will hand it off to you.
Thank you. Good morning, everyone. I'm really thankful to be able to share with you a little bit about how SOGI implementation has been going in Marin County Behavioral Health and Recovery Services. Next slide, please. So first, as many of you know, this work is incredibly important, and it takes a team of many people in order to do this implementation project. Most of this work, as was stated earlier, was held in a Delta Learning Lab. I was fortunate enough to have an opportunity to participate in one of their learning teams, Team Peacock, and that consisted of the California LGBTQ HHS network, specifically Mandy Taylor and Amanda McAllister Wallner, myself from Marin County, a LGBTQ community member with lived experience, and our coach, Jen Powell, who was really instrumental in helping thinking critically about this project, breaking it down into smaller pieces, thinking about sustainability. And then, of course, the internal team at BHRS. First and foremost, Audie, Vera, who thankfully is somewhere on this Zoom call. None of this work would have been able to be accomplished without them. They were absolutely instrumental in every part of this. Our LGBTQ collaborative, who provided a lot of feedback, particularly Dr. Suze Mitchell, who helped with that critical thinking and really thinking about how we can do this data collection on the SUD side. And then leadership support, which is critical. So our former BHRS director, Jay Africa, and our current BHRS director, Todd Shermer, were instrumental in supporting this work. The quality management team in taking what we did on the client profile and then putting it in our EHR record. And then our equity manager, Jen Moore, around supporting with additional trainings for staff. Next slide, please. So one of the things we did together as a team is got together and thought about how and where we wanted to implement some of these changes. We researched what other counties were doing. We looked at the Health Resources and Services Administration uniform data system. And what we decided to do is update our client profile form, given that was one of the initial forms that is given on intake. So we messed around with the different forms, looked at feedback from our stakeholders, and then finally decided to go with the form that you see on the right-hand side. One of the things that we did first and foremost is break out the name to chosen name. We want to really be trauma informed in our work. And one of the ways that we want to do that is not in dead name people. And so getting chosen name and pronouns. We also did sex assigned at birth as a new field. We updated our gender identity terms, and we also updated our sexual orientation values. So included in that is female, male, transgender woman, female, feminine, transgender male, man, male, masculine, gender queer, non-binary, additional gender categories. So we want people to have the opportunity to write in. And then of course, a decline to state. Sexual orientation, we updated it to include asexual, bisexual, gay, heterosexual, straight, lesbian, pansexual, and again, giving some additional sexual orientation that, again, people could write in, and a decline to state. Next slide, please. The next thing we did after updated it is Audie and myself collaborated on a SOGI roadshow. We worked with our LGBTQ collaborative on it. And then we trained our BHRS staff on it. And we called it a roadshow in the sense that Audie and myself went to different teams to present the trainings, we wanted to ensure that we could get as most staff as possible to participate in the training. So that's why we decided to do this roadshow approach. In our trainings, there was definitely an emphasis on the importance of gathering SOGI demographics and also giving additional resources, including a lot of those Fenway resources that were mentioned in our first presentation. They were incredibly helpful to our training. We worked with the quality management team to update the electronic health records with SOGI values and developed client resources to explain the new SOGI terms. Next slide, please. Some of our sustainability aims is to continue to elevate lived experience. So we have collected feedback from individuals that we serve. We are hopefully working with Rio on creating some kind of graphic recording of it. And we're going to be presenting that feedback to our staff. We're going to continue to train our staff, including onboarding procedures, and really providing those trainings that go beyond just the LGBTQ 101. Another thing that we're doing is creating more inclusive environments. So bathrooms, posters, pronoun pins, really just showing in our physical space that we are an inclusive, welcoming environment and that people belong in Marin County BHRS. Next slide, please. We're going to continue to utilize our SOGI data in practice, including measuring and reporting outcomes in order to guide our services. And as I said earlier, really modeling those best practices for being culturally responsive and trauma informed. And then finally, one thing that I'm very excited about is collaborating with other counties to advance collection and dissemination of SOGI data at the state level. There's, as many of you know, a lot of really interesting and good changes and coming with CalAIM. And so to be able to leverage some of those new changes, including new electronic health records, to bolster our SOGI data collection. And I think that's my last slide. Thank you.
Thank you so much, Dr. Blum. I think there's a lot of chatter in the chat right now, and chosen name, what a wonderful way to help someone feel accepted. Thank you so much for your work. And for the audience, please feel free to continue submitting questions in the chat, and we'll make sure to answer them in our Q&A. It's now my pleasure to introduce our next speaker, Gabriel Garcia Lopez, who is the Director of Health Information Systems at the LA LGBT Center. Gabriel, the floor is yours.
Hi, thank you. My name is Gabriel Garcia Lopez, and as Peter said, I am the Director of Health Information Systems for Los Angeles LGBT Center. I do have a couple of other of my colleagues with me, Claudia Alvarez, who's the Director of Performance Improvement, and Lisa Kimsey, who's the Director of Operations here at the Health Center. And so when it comes time for questions and answers, definitely have them to help with those questions. Next slide. So just kind of wanted to give an overview. I know that we've talked about SOGI and talking about what are the different components of it, and that's really what guided the way that we implemented it. So I'm going to really be talking about the technical implementation and what we've done in terms of providing SOGI data and collecting it from the whole life cycle, from the patient-facing side of it and how technology makes its way to the provider. And so as we mentioned with SOGI, there are the components of sex assigned at birth, differentiating that between gender identity, and then looking at sexual orientation and gender expression, all as distinct features that identify who somebody is and tells us the story of how to best care for them. Next slide. And so again, why is it important? Pronouns show respect for our clients. Gender identity is needed for gender affirming care. Sexual orientation also can help us with identifying any risk factors or ways that can help start the conversation of ensuring that they're getting the best care that they can. From a safety perspective, making sure that we know the right way to address patients when we're corresponding with them, and also being able to hold those conversations with information that's available to us. And then, of course, social determinants and informing ways that addresses health disparities. Next slide. So now we start getting into the more meat and bones of what we're doing at the center. So again, the way that we define it is different in our systems than the way that it's patient facing. We always want to make sure that whenever anything is patient facing, that we're always evolving in the way that we're asking the questions, and that as new terminologies come up, that we're also incorporating that into the way that we develop our systems that collect the information. And so on the left-hand side is the way that the EMR collects it, and this is how the fields are described, but for us, in parentheses, is the way that we present it to patients or the way that we ask the question. So for example, instead of saying birth sex, we like to use sex assigned at birth. The system says identifies as, but we call it gender identity. PGP was the way that they initially rolled it out, but we use that as personal pronouns or just saying it as pronoun, sexual orientation. And then we have administrative sex, and just differentiating that between administrative sex, which is usually used for more legal purposes, such as insurance, if they haven't changed it legally. And then we have preferred name, which I do love chosen name. And I think that that's something that we might want to consider in the way that we're presenting that to patients. And so we have preferred name that's also differentiated from the patient's legal name. Next slide. So when we've been collecting SOGI data in some form through analog methods or through paper for probably over a decade, but it's really been over the past 6 years that we really have been approaching it from a more programmatic standpoint. So we implemented our patient intake management system about 6 years ago, and we partnered with our EMR vendor to also look at the way that they could enhance the product. So what we didn't want to do was create these custom fields that existed 6 or 7 clicks away from the patient's record that you had to find this information. We wanted it to be front and centered. It should be a reflection of who the patient is, and it should be easily accessible from anybody within the organization that is touching that record, providing that whole person care. And so we really took that approach with it. In working with our EHR vendor and then also our patient intake management system, because what we want to do at the center is become really mobile first and making sure that there's the privacy and there is that flexibility for patients to check in and fill out their registration forms using digital methods. So what they're most comfortable with, using mobile devices, or if they come on site, being able to hand them a pad so that they're able to answer these questions in a way that they feel comfortable with, and using language that is meaningful to them. And so we really took that approach to that to be sure that we're collecting information that is meaningful for us, but also ultimately benefiting the patients and clients. We do have an integrated medical record that is also integrated with our behavioral health record. And so it really becomes important from a mental health services standpoint that we are providing information for everybody, like I said, that's touching the record to provide that whole person care. So you'll see that for birth sex, we're asking them for medical purposes, please tell us the sex that you're assigned at birth. So it kind of prompts them saying, why are we asking this information? And then we provide those options. With the patient intake management system, it is flexible, and we can always customize these fields, and we can always customize the way that we're asking it. And that's something that's really important to us, is because these fields and values are going to evolve over time. And so as we collect information, we start seeing that more and more people are identifying with a new terminology like pansexual. That's when we can go in and add that field and make sure that we are also reflecting where patients are as a community. And as that grows, we grow with it. And so that's kind of the approach we took with the way that we're intaking patients and making sure that we are bringing them all within the same technology, so that we have that information make its way into the EHR. So next slide. So once it goes into the EHR, as I mentioned earlier, we didn't want these fields to just be some custom field that exists 5 or 6 clicks away from the patient. It should be front and center. It should be normalized. It should be elevated to the level of demographics that are across the board. And so we worked really hard with our EMR vendor to really visualize what that looks like. And so it took us about a year to work with them. And they actually created these fields for us that now are available throughout the entire product, and is available for other organizations that want to use these fields as well. And so what's been great about that is if you look over to the right-hand side, if you open up the patient's demographics, you see that these fields exist. And then the way that it translates into the patient's face sheet, you see that at the top of the patient banner, you'll see their sex assigned at birth, and you'll also see their gender identity. So their sex assigned at birth is in parentheses, and then also in parentheses at the top, we also see their preferred name. So now we have information that helps guide the way that we're going to have that conversation with a patient, without dead naming and also honoring somebody's gender identity versus their sex assigned at birth. And down at the bottom, if you click on their demographics, you see again a snapshot of what their information is, and really helps guide those conversations with patients. Because these fields exist as discrete and structured data within the EMR, we're able to pool that for analytics purposes, and it also interacts with the chart in different ways. So if you go to the next slide, one of the neat features with it is if you look at the progress note down at the bottom right, it will update the patient's progress note to show if they are identify as male, female, or remove that if the patient uses a gender or a pronoun that's different than the traditional male or female. So in a nutshell, that's kind of what the Los Angeles LGBT Center has done to think about the way that we collect data programmatically using different systems and using technology to really elevate the way that SOGI is collected, used, and now we're starting to think about the way that it's shared as we start connecting with health information exchange and what are the implications of that and how does that information go to different organizations. So that's kind of where our mindset is now, that while we have this great foundation set up in the way that we're using SOGI to inform care, now how does this kind of speak to the larger health information exchange community, and how does this information go from a privacy security perspective, and with the political climate and where things are going, also being sure that we are walking through that and navigating it in a way that protects the privacy of our patients, but also encourages the coordinated care for our patients. Next slide. Oh. So I think that's it. I may have gone through faster than the time that we had allowed. But that is what we do at the center. We, again, stressing the importance of being able to customize those fields and making sure that they are mapped and sent over to our EMR in ways that are meaningful to our providers. And then it also makes its way to the patient portal. We have about a 75% adoption rate with our portal. So we have patients that are really tech savvy. And we wanted to make sure that that SOGI information does make its way to the patient's portal, and also honors and meets them where they're at in that journey.
Thank you so much, Gabriel. It is so wonderful to see how you all have problem solved around these different technical considerations, and then also to think about how we move into this future of wider data exchange, and look forward to hopefully maybe hearing a little bit more from you in the Q&A about what you all are anticipating or any challenges that might be coming up. With that, I have the pleasure of introducing our final panelist, Tracy Lacey, who is the Senior Mental Health Services Manager with Solano County Behavioral Health. And with that, Tracy, I will hand it over to you.
All right, good morning, everybody. Thank you so much. Next slide, please. So I have the privilege to share with you some of what we've done in Solano County, specifically around the community's voice and how we've really engaged our communities around the collection of SOGI data and real data, also really helping communities that may have felt invisible before be seen. Next slide. So I can't really talk about all this without talking about a very large innovation project that we did. The interdisciplinary collaboration and cultural transformation model. This was a MHSA innovation project from 2016 to 2021. This project was delivered in partnership between the county, UC Davis Center for Reducing Health Disparities, 3 of our CBO partners, Solano Pride Center, Rio Vista Care, and Fighting Back Partnership, and most importantly, the community. And so this was a 5-year project that the 3 communities of focus were our Latino, Filipino, and LGBTQ+ communities. The way these communities were initially identified was looking at our penetration rate data, if you will, around who we were underserving, the Latino and Filipino communities. In Solano County, we have a very large Filipino community. So while we have other Asian American communities, that community really is quite pronounced here. For our LGBTQ+ community, we weren't even really collecting any meaningful data. So that's that piece of invisible. If we don't even know who we're serving, how can we really be doing it in a culturally sensitive way? The core components of this project they were anchored in culturally and linguistically appropriate service standards, the CLAS standards. This is a national set of standards used by federally funded health agencies, organizations. So we adopted those early on in 2016 and have continued to implement them. The other core component was community engagement, really meaningful community engagement. So really getting directly from these 3 communities of focus, feedback from them, and I'll be able to share a little bit about that. Outcomes of this project, we increased access for all of the communities that were the focus of the project, reduction and use of crisis services as the entry point, and improved consumer satisfaction. There's a link to the final report there. This project, what we ended up doing is UC Davis did a year-long health assessment, if you will, focus groups, community forums, surveys for each of those 3 communities. I call it our report card. We got some not so good scores, y'all. And we pulled that together, did a training for multi-sector partners that represented these 3 communities. And those partners developed 14 quality improvement action plans. So these were community defined strategies for us to really increase access and to better serve our communities. The other piece of this project is the quadruple aim was used. So with goals of improving consumer outcomes, consumer satisfaction, provider satisfaction, and also to reduce costs. Next slide. So in order to get going here, as I mentioned, we weren't even really collecting any of the SOGI data at the beginning of this project. So we embarked on how to normalize, organize, and operationalize the collection of this data. We did a lot of communication with our providers, education and training. We developed a training specific to reception staff and then a separate training specific to clinical staff. You can see here kind of our steps here around organizing, adding sexual orientation and gender identity into our electronic health record in 2016. Then gender assigned at birth in 2017, and then, preferred chosen name added in 2017. So our electronic health record keeping up with some of the trends and changes, we have to really be mindful of making those adjustments and those changes. But the chosen name was added to the electronic health record ribbon bar. So when you open up a client chart, you'll be able to see the person's chosen name. Pronouns were added in 2021. And I will say in 2016, when we launched the first 2 fields in Avatar, our access line began to ask these questions at the first point of the call to request services. And of course, we have a prefer not to answer option, and people are able to do that. We also ask again with self-reporting tools. And then again, throughout the course of treatment, have an opportunity to update this information. Data collection process, we convened a work group to create culturally responsive self-reporting tools. This was particularly important for the youth clients. There was a lot of concern around parents and maybe youth that weren't out to their families. And so there was a self-reporting tools around demographics for the parents to fill out, but a separate tool that was created for the youth to fill out. And we made a decision to have that tool be for ages 10 and up. And in part because in Solano County, and like many counties, we have a fairly big problem with commercial sexual exploitation. And if folks are not aware, the average age is 10, that folks are exploited. And so we made this really focused decision around collecting for 10 and up. And so the form itself, when it's a youth filling it out, they're always filling out the form separate from their parent in a room with a clinician. And we did get feedback from our local Solano Pride Center and also youth around the way that we asked the questions. And so I do also want to highlight, as we did this kind of almost simultaneously, a little bit later in 2017, if you will, we also started implementing a workforce equity survey and are asking the same questions of our staff as well. Next slide. Wanted to share, this is one of the QI action plans that came out of the ICCTM project. This was the LGBTQ ethnic visibility QI action plan. This was one action plan that really looked at the intersect of the 3 communities of focus. Their goal was to create an anti-stigma signage campaign. They held focus groups with Latino LGBTQ community members and Filipino LGBTQ community members. And then we worked closely with our graphic designer to develop these posters that you see here. There were 7 posters developed in total. Over 700 of them were distributed in the community to locations that the Filipino and Latino communities frequent. So restaurants, stores, businesses. The group was really intentional around not putting the county behavioral health access line on the poster itself, but there's a QR code. And that QR code actually takes them to a subpage of our website that's focused on supporting the LGBTQ community. And there are different resources, hotlines, and our access line there as well. We do plan on developing posters for the African American, Native American, and Caucasian communities as well, and we'll be holding focus groups for those. Next slide, please. So helping invisible be seen. We have done a fair amount around welcoming spaces. We funded all of our county and contract agencies to buy materials that were representing diverse communities. We implemented culturally responsive school wellness centers. We more recently have been developing virtual backgrounds that are representative and inclusive for all. And if somebody doesn't mind, we also have done some significant multimedia campaigns. If somebody can put that link in the chat for me. The story arcs that you'll see in these commercials were developed with the community. These communities let us know what their challenges are. And so those commercials were really telling their story. Next slide. These are just some quick slides just showing how we're using data. So these are data dashboards we created. This particular one's of our children's system of care. So looking at the demographics of who we're serving, from race to language to gender identity, sexual orientation. We have this for our adult system as well. And then we also have it for our access timeliness. So we can kind of see who's calling in. I love that little timer, super helpful. So we can kind of see who's calling in, helps us do a little bit more targeted outreach. And we're putting all of the, I call it the equity lens, in all of our kind of dashboards or any of our reports coming out of our electronic health record, if we're looking at quality of care, we have to be looking at it from that equity lens. Who are we serving? Next slide. This slide here is just also a kind of a look of how we're using this data. This is our school mobile crisis calls by sexual orientation and gender identity. So we do look at all of the demographics for we have 2 mobile crisis programs, a community-based and a school-based program. So we look at everything from race and language and insurance type, all of those things. And because we have SOGI data in our electronic health record, now we're actually able to see these calls that are coming in via the SOGI data. So you can see this is the most recent kind of look at the data. 52% of the calls were for students who identified as non-heterosexual. And then 8.7 of the calls were students that identified as genderqueer, transgender, non-binary. So this is huge for us to know this information. This really tells us that our LGBTQ students are at great risk for suicide. It helped us really do a call to action for our school districts for them to infuse more training into the school districts and the schools. We fund Solano Pride Center to provide welcoming schools curriculum. And so when this data was sent out to the districts, they responded very quickly and started pulling in different folks to come in and do trainings. We also look at our suicide death and overdose death data by race. Currently, SOGI data is not collected by coroner's offices, but we've been working with them on including that as well. But it really helps us kind of see where we need to focus our attention and services and treatment. And with that, I will end. That was my last slide.
Thank you so much, Tracy. So incredibly valuable to see how Solano County is putting this into action. And with that, we get to turn to Q&A with our wonderful panelists, noting that our colleague from the Fenway Institute did have to hop off early, but we have all of our other folks here. We've been getting a lot of questions in the chat. And just want to remind folks as well that if you would like to ask a question for our panelists directly, that you can raise your hand and we can unmute you. So want to encourage that. While folks are finding their raise hand feature, I wanted to kick us off with a really great question that came in the chat, because I know this comes up a lot. And I want to open this up to all panelists. And I'm wondering if folks could speak to guidance on what the response options or categories should be included within gender identity and sexual minority questions. I know that speaking from the behavioral health space, this comes up a lot due to different guidance from different payer sources when it comes to asking these questions. And so, Dr. Tien, I don't know if we want to kick it off with you and you can kind of share from the Medi-Cal perspective, or if you have any thoughts, and then I would love to open it up to our other speakers.
Yeah, thanks. I'm happy to start. I think that there's probably going to be different ways of answering this question. And as some of our presenters mentioned, this will be an evolving space as well in terms of what the best practices are. I would say kind of 2 general things. One is that there is the context of policy from laws and regulations, some of which I covered in my presentation, such as making sure that there is a non-binary gender option. You know, that's part of California law, as well as thinking about how to ask about sexual orientation and gender identity. And that some of that is specified also in the statute based on laws that have been passed. From a data collection perspective, in terms of what fields are used, I think that from a policy and kind of data perspective, I think that interoperability and data exchange have been mentioned, but we want to make sure that there's enough of a general agreement and data are being collected in a way that it can be shared with other people if appropriate. So a lot of folks have been talking about innovations and ways that they have constructed their EHRs, for instance. We saw several examples today of how to show, how to ask and show sexual orientation, gender identity, and race and ethnicity data, for instance. And then when we think about how to capture that information, you know, part of what I mentioned in my presentation were these US CDI, these interoperability standards, but there are certain standards on data exchange that are used. So that, for instance, if the LGBT Center wants to share the information with another stakeholder, for instance, about a particular person, when that information is shared across either like EHRs, et cetera, the other entity will know what that information is. Because, for instance, if somebody called, one field A and somebody else called the same information B, like there's additional work that needs to be done to kind of reconfigure the data and so forth once it gets transferred over, which is a long-winded way of saying that I think that we should definitely be considerate of, especially breaking out of the patterns and kind of like binary status that have characterized the space for a long time. I think that in terms of the exact answer of what field to use, there are certain things like statute and kind of guidance for interoperability. And then, DHCS is thinking about how that information is collected. And often it will be different at the direct service level compared to what, say, we ask for on an application, and there are many reasons for that. But I think that I don't think DHCS is currently mandating, for instance, anything that a direct service provider gets like to that level of specificity, and that's probably more of a conversation between a service provider and the managed care plan in terms of like what data are collected, with the caveats that I mentioned earlier.
Thank you, David. Lisa, did you want to jump in?
Thanks so much. So one of the things that we do is we really try to keep our ear to the ground. So we use Phreesia as a system that clients do their initial registration and mark their identities. And we monitor, we have a space under gender and orientation where clients can write in, if they don't choose the options, how they identify. So we started noticing, I've been at the center for 15 years. We started noticing about 10 years ago that a lot of people were writing in pansexual, right, as a sexual orientation. So once we started seeing that number, 3, 4, 5, right, 6, 7, 8% of the people that were, completing the registrations were identifying as pan. So we moved that, as an option. So Gabe talked a little bit about, monitoring how patients are identifying and, making sure that we're staying current with that. So once we start seeing something move, up above 1%, 2%, then we're looking at incorporating that. And then we use Veradigm, formerly known as Allscripts, and we basically look at the identities and match them on the back end into UDS so that, it's streamlined.
Yeah, and Lisa brings up a good point about UDS. That's kind of we're a federally qualified health center, and so at the end of the year we have to report using the uniform data system, and so that usually is kind of our guiding tool for how to classify. But then we can map beyond that. So it might say male, female, intersex, but then we're able to go beyond that if there's anything that needs to be configured, or for sexual orientations, like Lisa said, there's pansexual, but there's not really an option for that in the UDS, but we're able to map that value to say, okay, that's going to be included under the 5 different categories that UDS has. That at least provides some structure, and I think the US CDI is also based off of that, or vice versa. And so that's a way that we're systematically kind of approaching it, so that there is some level of governance around it and some structure with it. And so I think that eventually will become part of the larger discussion nationally of how do we incorporate this while still being reflective of the communities that we're serving, and providing that the way of identifying and evolving with our communities.
Thank you so much, Lisa and Gabriel. Dr. Blum, did you want to weigh in on this one?
I did, because I did see when I was talking some things come up in the chat. And one of the reasons why we have it on our form as broken out: sex assigned at birth, gender identity, sexual orientation, chosen name, legal name, is that client profile form is what is entered into the share care. And so we do need some of those fields to line up to what is it, Medi-Cal, in order to get reimbursement for services. The way it was before that was if it wasn't and people would just mark things, it would just like get thrown back. And so what we wanted to do was to be able to have a form that ShareCare could have what it needed, and we could have the clinical information on the client facing, the client face sheet and what service providers are using, and really talking to the individuals that we serve that we need to ask these questions just for the insurance purposes, but we will call you by your chosen name. We will call you by your chosen pronouns. We will respect your gender identity. We just need this stuff to fill out the forms for DHCS.
Thank you so much, Dr. Blum. And just want to open it up, see if there's any other thoughts on this from any of our other panelists or any additions based on what your colleagues have shared. We solved that question just like that. Super helpful. I will say, it's really, I did want to kind of know what you had pointed out, Gabriel, with what is going on at the federal level with the UDS and USCDI and how those are reflective of each other. And just want to note that those are under revision. I believe they're currently collecting comments on USCDI version 4. I might be wrong. They might already be on 4. Okay, I was right on that one. It was 3 last year. So we can put the link to that in the chat as well, so folks can check that out. And with that, I'm going to pass it off to my colleague, Peter, to follow up with another question for our panelists.
Thank you so much. So this question is also for all the panelists, and it was somewhat addressed in the chat, but I wanted to get the perspectives from the panel. So an audience member shared that they've gotten feedback that asking sex assigned at birth is anti-trans and to just ask for gender identity. Any thoughts on this or response, or how did you navigate this at your practice?
I could just to kind of echo what I was saying earlier is really being transparent with the individuals that we serve, that we do need to collect this because the way that the way that our Medi-Cal reimbursement works is that it has to align with what is in Medi-Cal or we get denied. So one, being very transparent with the individuals we serve, training staff to talk to the individuals we serve and being transparent about why we need to collect this information, where this information is going, and equally how we are going to not disrespect you and how we're going to honor your pronouns and your name and your gender identity.
Go ahead, Lisa.
Oh, thanks. Yeah, I had typed in chat. We look at it the same way that Vanessa was talking about, that the transparency piece, I think, is really, really important. I've had those conversations myself with clients before, and the way that I explain it to them is that, we're always looking for, more funding, right? So, we have a research prep study right now. We were able to open a trans wellness center with collaboration from other partners in LA County. And without being able to identify the size of the population, right? You see this in HIV care all the time, that, being able to kind of define how many people you have in a population helps you be able to apply for different types of funding. And, if we weren't going for those types of funding, I think somebody had put in the chat, like, we really need to have a conversation about doing that with behavioral health. I would ask, if we don't have a reason for collecting it, then we shouldn't be collecting it, right? If you're not getting reimbursement that depends on that, then does it really matter? You know, if somebody's in private practice as a mental health clinician, they probably don't need to know that, right? If it doesn't come up. So I think it really, asking that question depends on where you're getting your money from and, you know, how you plan on helping whatever community you're helping. So, you know, like I just pulled the number yesterday, we have 4,755 active people whose gender does not match whatever their sex assigned at birth was. So the, you know, knowing that number can be really valuable when you're applying for services or talking with other stakeholders, and even talking with our own clients. Sometimes I think there can be a value to that.
Thank you, Lisa. And I see that there's an audience member with their hand raised. Before we unmute, did any of the other panelists have any thoughts on this?
Sorry, go ahead, Tracy.
No, go ahead.
I was just going to reinforce or remind, so like in our patient intake management system, we are always able to customize the way that we're asking the question. And so that's always a great opportunity to say, for example, we say for medical purposes, so that at least it kind of leads them in the direction that we want them to go to, but we can always follow up saying, this is why we're asking, this is, you know, why the medical purposes are relevant to your care.
And I was just gonna say what Vanessa had shared earlier around just transparency and humility, right? So just being really honest with the community around why we're collecting this information, what we're gonna do with the information, and why it's important. I think that's really key. And what we hear from our communities when we've done all of the different focus groups for all of the QI action plans, like they really want to understand why things are being done.
Awesome. Thank you all. Diane, did you want to unmute and ask a question to the panelists?
Yeah, thanks. I really appreciate this this presentation. We've done a lot of work in San Francisco around SOGI, and one of the one of the issues that I'm curious about is at what age do you, and you may have covered this, and I'm sorry I had a conflict and I got on late, but at what age do you start asking about some of the SOGI data, and what are some of the issues that are coming up, and how are you handling that? Thanks.
So at the center, we're typically seeing people that are 18 and over. So for us, it's just part of our regular intake documentation. But I do believe that from Fenway, they were talking about recommending for patients under 12 with also parent consent. So, but I don't want to kind of speak for Fenway, but I think there probably is some resources online that speak to that age type of collection.
Anybody else want to share about how young they're collecting data from patients?
So our client profile form is used both in our adult system of care and our child system of care. So individuals sort of that 12-year-old range who are coming in and completing their own forms are doing it. And then for younger kids younger than 12 who are coming in with a parent, it's a parent in conjunction with a child doing it, but similar to and I feel like it was one of the other speakers was saying, and I feel like it was LGBTQ center, to have private conversations with the kids afterwards, sort of when you're doing the intake and just kind of going through, hey, this is what your parent put down. Does that seem right to you, particularly around gender identity? And Tracy, I'm sorry, I feel like you and I were both going.
That's okay. Yeah, I think I mentioned during my presentation, we're collecting the data as young as 10. And that is really because we have a big problem with CSEC here in Solano County. And the work group that was involved in creating the youth forms were very aware of that. So 10 and 11-year-olds, generally the clinician is verbally asking the questions and filling out the form for them. So a verbal interview, and then the 12 and up are filling the form out themselves. And again, away from the parents, the forms we developed, we also are asking youth if they're out already to their families. If they're not, do they want help with that? Is there anybody that they are out to, that is somebody that can be leveraged as an ally? A lot of thought was put into this. The self-reporting forms are scanned into the electronic health record in a section that cannot be released to the parents. And so a lot of planning went into, again, the operationalizing of this collection of this data.
Thank you all so much. I did want to circle back on one thing that folks, I think Lisa had pointed this out, as well as our other panelists, of, you know, the need for asking for certain data elements like sex assigned at birth. And this has been something that has been coming up, particularly for county behavioral health and providers for a while, and have been working with the department to make a change in the claims system. So that way, you know, when we submit claims, they're no longer going to be validated by that gender or sex assigned at birth. And so just really kind of demonstrating the partnership with Department of Healthcare Services as we move towards a more inclusive and affirming system, even if it's on the back end. I mean, everyone has done so much with their EHRs, you know, to ensure that that clients are seen the way they want to be seen. But I think that also just kind of shows how, you know, how our systems can shift as well. And I do see that we have one more hand raised, and I think that this will probably be our final question. And I apologize in advance if I mispronounce your name, Kevlin?
Hi, yes, you pronounced that right. Hi, everyone. My name is Kevlin, they, she pronouns. I'm a trans feminine person in California working in intersectional data justice. And I guess this is kind of a hybrid question and commentary, especially with that question regarding in the chat about, you know, asking about sex as anti-trans or rhetoric or sentiments around that. And something that I'm continuously noticing is that while a lot of us here as medical professionals or healthcare providers can agree that sex and gender identity are uniquely different and distinct, that there's oftentimes a conflation between the two and assumptions made about gender based on sex. For example, in different records shown today, you're seeing that, you know, people are having the options as transgender, but then male and female as other options, whereas which I enjoyed about the LGBT Center in LA was that there was different selection options for each, whereas gender identity had its own selection options, whereas sex had its own selection options with transparency and information about why this information is being collected. So I guess my question originates with all this, with 2023 only being 2 months in and having over 330 anti-trans bills, especially weaponizing words such as sex and gender and conflating the two, that how are we as medical professionals keeping each other accountable into how these conflations can be weaponized against each other and especially for the community, and then also provide misinformation into the community as well about the connection between the two. Because right now it seems like people are acknowledging that there is a difference and there are unique differences between the two, whereas gender identity may be more behavioral, social, psychological, and, you know, sex being something more biological or genotypic, that they're often used interchangeably to minimize each other's effects, especially in how we do data collection. So I guess my question to the panelists would be, how are we keeping mindful of these things and how they're being weaponized, especially in terms of policy and erasure of groups such as intersex? So yeah, I guess that's just my question. Like, how are we staying accountable to that and making sure that each other's data systems are accountable rather than continuously relying on the community for that work?
I feel like that's a whole nother webinar. That's a big question, but an important question. Yeah, I mean, we get a lot of questions, particularly in our school wellness centers, because we do ask the SOGI data in middle schools and high schools. And so we've gone to some of the school board meetings and answered questions around, again, why the data is being collected and how it will be utilized, and making sure that it's not weaponized. And I do think, there's a lot of work to do between the state and, and the counties, and not just behavioral health, but other entities as well. All of our demographic data, whether we're talking SOGI data or race data or ethnicities, they're all different data values, if you will. It's very challenging, and to keep all of that up to date and current, and to keep an eye on what's happening in communities and violence is really important. So, in terms of supporting the staff and the consumers, having a place for people to talk about what's happening in the world is really important. Having open spaces with your teams to talk about this and answer their questions that might be coming up too around asking this data and potentially putting their clients at risk. I think that's important. Then I'll be quiet and let someone else respond.
And thank you so much, Kevlin, and for the question, and Tracy for responding. Unfortunately, we do have to move on to the closing. But yes, maybe we could address this in a follow-up or a webinar. But I want to hand it over to our colleague Rio Holiday, who has been listening very closely to this conversation, and we'll be sharing a graphic recording of the entire webinar and panel today.
Thank you, and hello everybody. My name is Rio, and I want to give a quick summary of what I've captured so far. You will have access to this. I know it's a tad bit blurry, but what I want to do is just share some of the high-level things that I've heard, which are really captured in these highlighted pieces. So we started with this question of why collect SOGI data. And we talked about the fact that there are unique health disparities among the LGBTQIA community, and that we need to know folks' identities so that we can provide culturally tailored care and end the invisibility of LGBTQIA patients. We talked about who needs to be trained, and this came up across multiple presentations. And I'm actually going to zoom in just a bit in terms of clinicians, non-clinical staff, and patients. We talked about when this happened. It could happen, for example, at registration. It could happen under 12 years of age. It should happen in private. And then multiple folks gave examples of how you're asking these questions. We talked about ways to encourage SOGI data collection as well as real data collection. One of the themes that came up in some of the local examples were including folks with lived experience in designing and developing these interventions, for example, through focus groups, community feedback, or surveys, as well as being part of the team. And then finally, we talked about how you present information being important. That's both the language and the explanation for why, the importance of flexibility and customization. And in terms of what's coming next, how this information is shared and balancing that coordinated care with privacy and security, political climate, and the national requirements and statutes versus what is happening and true to your community. And with that, I will turn it back to Peter. Thank you.
Thank you so much, Rio. That is a beautiful graphic summary, and we'll be sharing this with everyone, and it will also be posted on the Delta Center California website. Thank you to all of our speakers, and Naomi, if you could share the slide. We're asking everyone to please complete an evaluation to let us know how this webinar went. And we do use this feedback to help inform, our future planning for other events and collaboration among Delta Center California. Yes, that's it. Thank you, everyone. I know folks may have to go to another meeting, but please visit the evaluation website and or scan it on your phone or iPad. And if you could complete the evaluation, we would greatly appreciate it. Thank you so much to everyone that supported this webinar, JSI, the program staff, CIBHS, and to our wonderful panelists and our engaging audience.
Thank you all.